Welcome to our webinar this evening. My name is Jess, for those who don't know me, and I'm part of the PKD Australia team. Tonight's webinar is titled Arteries Under Pressure, Vascular Health, Hypertension and PKD. Jackie, over to you.
Thank you so much, Jess. And look, it's an absolute pleasure to be here. I was delighted to be asked to speak, and I'm really looking forward to being able to share some of our research with you. So I'm going to share my screen. Hopefully that will all come out nice and clear for you all.
Yep, you're good to go.
Thank you. Okay, so I'm going to be talking today about the research that we've been doing and the area of focus that's currently undertaken in our lab, looking at the blood vessels and how blood vessels are affected in PKD and a particular component of that change. So, as many of you would probably be aware, high blood pressure or hypertension is really common in association with polycystic kidney disease. So up to 70% of men and up to 50% of women with AD-PKD will present with high blood pressure. We know that both high blood pressure and also polycystic kidney disease increase the risk of cardiovascular disease in people. So that's heart disease, heart attack, and stroke being some of the key risks that might occur because of these two conditions coming together. Cardiovascular disease is a major cause of death across many different types of chronic kidney disease, including PKD. So it's a really important consideration. Just going to get those slides moving. So what I want to talk today about specifically is vascular stiffness. So what is vascular stiffness? Vascular stiffness is an important risk factor that's associated with kidney disease, and it's associated and it increases in importance in association with a decrease in kidney function. So a hardening of vascular tissue or arteries occurs when we get an increase in a deposition of calcium and phosphorus actually within the blood vessel wall. We also get a process being undertaken that involves the normal blood vessel cells, so what we call a smooth muscle cell, transforming into a bone-like cell. And what this does is it causes the arteries to become stiff. So if you imagine a rubber band, so your blood vessels are a rubber band, if you stretch that rubber band, I don't know if you've got a hair up in a tight moment or something, you can stretch that rubber band, you can feel it stretch. And then if you release it, you'll slowly find that it'll come together as well. So it's got this nice elasticity. What happens when we get vascular stiffness is we lose that elasticity. So we lose that capacity for the blood vessel wall to stretch and then to slowly come back into shape. As this blood vessel becomes stiff, it has a number of flow-on effects. So it increases blood pressure and also increases the pressure that the different tissues around the body feel. So it increases the risk of damage to those vital organs. So it's a really important change that impacts how the pressure in the body is then causing damage to the tissues of the body itself. So how do we measure vascular stiffness? Okay, so in people and also in our animal models, we do a non-invasive measurement in people called pulse wave velocity. And what that is actually taking two probes. In this particular figure that we've got here, we've got a person, schematic for a person lying down. You can see we've got a probe at the carotid and a probe at the femoral artery. They measure what we call the pulse wave. So every time your heart beats, it goes beat, it causes a flow of blood through the body, but it also causes a pressure wave through the body because it's a closed system. And that pressure wave has a certain shape, and you can see that shape down here measured at the carotid, where you get a heartbeat that causes an increase in pressure, and then it slowly declines. We can measure that pulse wave or that pulse change at two different points of the body. So here we've got the pressure wave at the carotid marker here, and here we've got the same point on the wave at the femoral marker here. And we can measure how fast it takes for that pulse wave to actually travel between those 2 points in the body. So we can actually get what we call a pulse wave velocity. So if you imagine our blood vessels that are nice and elastic, what happens is when the heart beats, they expand and then they slowly contract. And so you get a nice controlled wave of pressure going through the system that controls the flow of the blood. Imagine we've taken our nice elastic blood vessel, we've turned it into a rigid tube, so a piece of pipe or a piece of hose, say. We no longer have that capacity for the blood vessel to buffer the pressure and then slowly release. And so what happens is we get a much faster pulse wave velocity. And so that's how we can actually measure vascular stiffness, and we can do the same sort of thing in our animal models as well. So what is it about vascular stiffness and PKD? In PKD, arterial stiffness, or an increase in this stiffness, is an early warning sign. And it's actually seen quite early in people with PKD, even often when kidney function and blood pressure are within a normal range. And this stiffness can be an important predictor or a predictor of risk of future heart disease and stroke disease. In PKD, we also see more pronounced stiffness than in other kidney diseases because we also see arterial stiffness in other kidney disease. But research comparing different types of kidney disease shows that people with PKD have significantly stiffer arteries than those with other kidney diseases, even when matched for age and kidney function. So it's a really important factor for us to consider in PKD. So what causes vascular stiffness? There's quite a few things that cause and contribute to vascular stiffness, but the one I'm going to focus on is vascular calcification. So vascular calcification is associated with the deposition of calcium within the vessel wall. So there's two different types of vascular calcification. One which you might be familiar with is called associated with atherosclerosis. So atherosclerosis is where you get a change in the blood vessel wall associated with deposition of plaque. So that might be lipids and cholesterol, and also calcium in what we call the intimal layer of the vessel. So if this is our blood vessel here, the adventitia is the outside. The media is composed of smooth muscle cells, which are what gives the vessel the capacity to stretch and then contract. And then we have the intima, which is the inside layer. So atherosclerosis is associated with this plaque forming within the intimal layer and calcium deposition. What we see in kidney disease is called medial calcification. Another term for it is arteriosclerosis. So in medial calcification, we actually get calcium deposited within the smooth muscle cells themselves within that vessel wall. Now, we also see medial calcification in association with aging. So as you get older, it happens to all of us, but it's accelerated in kidney disease. So we get this deposition of mineral deposits within the vascular tissue. It's, as I said before, it's accelerated in PKD, let alone in kidney disease, and it leads to this increase in blood pressure and associated tissue damage. And one of the key issues with medial calcification is it's hard to treat. So once it's established, it's very hard to reverse. So these are just some images showing vascular calcification. In this case, they're not PKD patients, but they're kidney patients in this particular case here. And this is done with a CT scan or computed tomography. So it's a non-invasive way of looking at calcification. So this is the person's heart here, and this is their aorta. And these lines are just showing how they've divided the aorta into different parts. But what I want you to notice is these white lesions. That's calcium. That's calcium in this beautiful, what should be nice elastic aorta. And we've got this deposition of calcium within the actual vessel itself, both in the aortic ascending component and also the descending component here as it's running down to the body. We can see a similar thing in our animal models. So this is an example here of an animal model. And this animal model's been had kidney disease induced, plus they've had calcium and phosphorus and vitamin D added to the diet to drive this process. So in the animal model, what we do is we've also got a CT scan, and this time the animal's sort of side on, the animal's head's up this end and its tail's down here, and this is the animal's heart. And you can see these arrows are pointing to this fine white line that's actually lining the aorta. Now, the key with this image, you can see this white here of the bone. That's what bone looks like. So we're actually seeing a similar deposition as to what we would see in bone. This is the same animal, but it's imaged from a different direction, so it's cut through the middle. Here's the animal's heart here, and here's the aorta again. You can see this calcium deposition, and here's the bone. So we can see that we're getting this deposition of what we would normally only see in bone in the vascular tissue. So it's a really critical change that affects the function. So what causes vascular calcification? And that's really where our research is lying. So there are a number of different mechanisms, and they're really not well understood, particularly if we're thinking about how we would change them to prevent or reverse the process. So within the vascular smooth muscle cells that I've talked to you about before, so the abbreviation I've got here is the VSMC, the vascular smooth muscle cells, there's two processes that are undertaken. One is a passive process where we get a deposition of calcium and phosphorus within the smooth muscle cell that's associated with changes in mineral homeostasis within the body and increased levels of calcium and phosphorus circulating. We also have what's termed an active process where the cells change what we call their phenotype or their type. And that's where they differentiate, so they change from a vascular smooth muscle cell into a bone-like cell. So we call it an osteogenic-like cell, which is the bone-like cell. This is driven by changes in two different pathways. One is associated with what we call calcification promoters, so things that promote calcification, which you want to see in bone, but you don't want to see in smooth muscle cells. And then a decrease in vascular smooth muscle cell markers and calcification inhibitors. Again, we want those to be increased in our vascular smooth muscle cells. We don't want to see them going down. And we know that it's a change in the expression of these different pathways that is a driver towards vascular calcification. So I mentioned the animal model. I just wanted to give you a little bit more information on the model that we use. So this is a model of polycystic kidney disease. And one of the key things about this model that you can see if we look in this top panel is the animal's blood pressure. So I mentioned that high blood pressure is a key feature of vascular stiffness in people and also kidney disease in people. It's the same in our animal model. So this is the age of the animals from 7 through to 14 weeks of age. This is their systolic blood pressure. So that's the top half of the blood pressure reading. The blue line is our normal animals. As you can see, their systolic blood pressure sits at around 110, 120, which is what you'd probably also see in a person. In our animals with polycystic kidney disease, even at 7 weeks of age, so it's quite young, this is an autosomal recessive model, so it starts quite early, their blood pressure is already up to nearly 200 millimeters of mercury by 7 weeks and over that at 14 weeks of age. So they show the same changes in blood pressure. This is just showing the kidneys of the animals in the bottom panel. So this is a normal kidney from a normal rat. We've got, if you look closely, you can see some of the glomeruli here that filter the blood. This is part of the kidney that collects the urine. So that's a normal structure of a kidney. This is an animal the same age, but with polycystic kidney disease. And you can see that the normal kidney structure has been replaced by these fluid-filled cysts, and the whole architecture of the kidneys completely changed. So these animals have quite a marked form of polycystic kidney disease. We also see the similar changes in the vascular calcification in these animals. So this is the aorta of two animals. We have here the Lewis animal, our control, on the left, and our polycystic kidney disease animals on the right. In our normal animal here, you can see the normal layers of the aorta. This is the outside, and this the adventitia layer, and this is the intimal layer on the inside. And we've got these are the nucleus of the blood, the smooth muscle cells, and these are the smooth muscle cells themselves in a nice ordered structure. In our diseased animals, and the same animal, in both cases here, we've stained the tissue with a stain that's called von Cossa that picks up calcium. And you can see these black deposits here, that's deposition of calcium through the vessel wall. So we get the same changes in the vascular tissue in these animals that we see in people. And so we can use the tissues from these animals to study the disease process to try and understand some of those mechanisms that I was talking about. The other thing we can do is we can also use cells from these animals to develop a culture system. So what my team have done is taken smooth muscle cells from the aorta of these animals, both diseased and normal, and grown them in culture. So in culture, we can do lots of other types of experiments to also look at the mechanisms that drive calcification. So this is just showing you some beautiful images of cells. These are vascular smooth muscle cells from the aorta. And you can see we've got a whole plate full of cells here, and this is in higher detail. And this is just showing some of the markers that we use to identify these as vascular smooth muscle cells. So we have two systems in which we can actually examine some of the mechanisms and the pathways that might lead to calcification. This next image is just showing how we can induce calcification in the culture dishes. This is showing smooth muscle cells that are being treated with a special media that drives calcium deposition. And you can see here stained in red, calcium deposition in the smooth muscle cells. We can also look, this is what we call a macrocalcification, so it's calcium that's at quite a high level of deposition. We can also look at what we call microcalcification. So this is looking at calcium at earlier stage of deposition and different forms of calcium deposition with a different staining technique. And you can see here another image where we can see this calcium that's been deposited within the smooth muscle cell. So this is showing the vascular smooth muscle cells in culture and our ability to calcify them. So again, we can look at what's happening within the cells that's driving the calcification process. So our research questions are really looking at the mechanisms, trying to work out what are the factors that drive vascular calcification and also that change the cell type that lead to the increase in vascular stiffness. So that's looking at that process that causes this, both the deposition of the calcium and phosphorus and also the change in the promoters and the inhibitors that cause this transdifferentiation of our vascular smooth muscle cell into the bone-like or the osteogenic-like type cell. So that's a really important factor. And that work applies to both PKD and also it applies to chronic kidney disease across a number of different forms as well. What we're also looking at, particularly because we have a model of PKD, is what is it that accelerates the process in PKD? So we're looking at what is it about PKD itself that directly affects the blood vessels. And part of that will be looking at the genetic mutations and what is about those mutations that could cause an acceleration of that process that we're already seeing happening. So I'll just sort of summarize a little bit now as to, why is this important? We know that stiff arteries increase the risk of heart disease, heart attack, stroke, and other complications, making heart and blood vessel health a really important priority for people with polycystic kidney disease. Early detection and management of vascular stiffness could really help reduce some of these long-term risks associated with heart disease and stroke. And ongoing research is really needed to explore both the mechanisms that drive the calcification and the switch in type, but also to better monitor and treat the vascular changes in PKD itself. Some of the challenges is in people, calcification is different in every person. So as you saw from that picture I showed you from a person with chronic kidney disease with the CT images, it wasn't a really, discrete pattern. It was quite variable. And this will occur in different person to person. So it can affect different parts of the cardiovascular system, from the limbs through to the heart, and the size and the pattern of the deposits will vary. Early detection is difficult. So those microcalcifications that I was talking about that we can pick up experimentally, you can't see them on a CT scan. And so it's often only possible to pick up the actual calcification in advanced stages. And it's also hard to distinguish that atherosclerosis that I talked about from the medial calcification or the arteriosclerosis that's specific to kidney disease. So that's also make it difficult in our sort of diagnosis and prognosis process. The other thing with vascular calcification is there are currently no approved treatments that can reliably reverse the process. And any new treatments that we do look to explore will need to be balanced really carefully to avoid any unintended harm. So going forward, in terms of vascular calcification, I want to sort of clarify this, that certainly it's really important to discuss treatment with your specialist. I'm not a clinician, so this is not my area of expertise. But currently, some of the focus clinically is around phosphate control, because we know phosphate is an important part of that process. So both dietary mechanisms and also non-calcium containing phosphate binders. In terms of vascular health, really critical for this and all aspects of the cardiovascular risk is management of blood pressure, and also glucose control and lipid level control, because we know they increase cardiovascular risk, and also lifestyle factors, so diet, exercise, and smoking, because these are all extra things that build the risk for cardiovascular disease. So being able to reduce those will also therefore reduce the risk associated with the calcification that's also occurring. So it's a complicated process, but this is the one angle that we're looking at. So look, I'll stop there. But what I would do is firstly just like to specifically acknowledge two particular people that have really contributed to the work in this space. So that's Dr. Smuda Gangoda and Ms. Ashley Hicks from my laboratory, and also acknowledge the support of the PKD Foundation Australia, Hillcrest Foundation, and Macquarie University. So I know that Jess now wants to go to questions, and there were some questions that did come in before the session, and there are two that I can actually address now. And the first of those questions is around a difference in risk of cardiovascular disease for people before dialysis versus after. And in that regard, the risk of cardiovascular disease, we know, increases in association with decline in renal function. And that includes when people get to the point where they're needing renal replacement therapy. So yes, there is a difference because it's associated with where you are on the sort of the spectrum of renal function decline. And we know that dialysis itself can increase the risk of cardiovascular disease further because of dialysis related factors. So yes, there is a difference before and after dialysis because of that increase in terms of the renal function decline and also dialysis itself. The other question that came in was actually a really important point, was, does parathyroid hormone play a role? And yes, it does. Secondary hyperparathyroidism, which is what occurs as a complication in people with kidney disease, can contribute to vascular and valvular calcification. So this is calcification within the valves of the heart. because parathyroid hormone is a really important mediator of calcium and phosphorus levels in the body. So increased parathyroid hormone can lead to disturbances in calcium and phosphate metabolism that we know is one of the factors that drive vascular calcification. So look, I think they were really good questions, and I was happy to be able to answer those. And what I'm going to do is I'm going to stop screen sharing, and hopefully Jess is back on. And if there's any other questions, I'm happy to address those. Thank you.
Thank you so much, Jackie. Yes, that was fantastic. Please feel free to add more questions to the Q&A. As Jackie has already iterated, she is a researcher, not a clinician. So if they're more research-based questions, that's great. We have had one come through, which potentially may be, again, more the clinician side of things. But I have been told that my bone density is low, so I need to actually increase my calcium intake. But yet the calcium builds up. So which is more important to worry about? Or perhaps let me rephrase it from a research point of view, is there that direct correlation between increasing your calcium intake and therefore increasing the risk of that deposit taking place?
Yeah, look, there's a condition called calcium. Calcium bone metabolism disorder, and that's part of this overall profile of changes that we see in association with kidney disease and these disturbances in our hormones that modulate the minerals. And so we do get this imbalance, which can affect bone as well as vascular tissue. So look, it's a really important question. And bone health is also critical because fractures are something that people don't want to incur because of decreased bone density. I'd have to defer to clinicians and nutritionists around what to do in that space. But I know certainly in terms of bone density, there's also benefits from exercise and weight bearing and load that can be used that will also be of great benefit for your cardiovascular health. But yeah, no, look, it's a really complex picture. And if you're getting vascular tissue impacted because of disturbances in mineral homeostasis, you're also equally likely to have bone impacted as well. So it sort of fits with that big general picture.
Fantastic. Thank you. So may I ask the next steps in your research? I guess from where I'm sitting, it looks like first it's that identifying why it's taking place. And then the next step after that would be identifying how to treat it.
Exactly, yeah. And so to identify why it's taking place, there's a number of pathways that we're looking at. And so what we can do in the animal model, for example, if we identify that one of those pathways is perturbed and abnormal, we can then look in the animal model as a first step instead of what we call preclinical studies, and also in our cell culture to see if it's a excess of something or a deficit of something. If we can replace or inhibit, does that reduce the process or slow the process down? So yeah, so that's absolutely something that we're looking at. The other thing we're looking at is, as I mentioned, what are PK specific factors that might be involved? So there's a particular pathway associated with PKD mutations that's associated with DNA damage, which we know accelerates vascular calcification. And so that's one particular pathway that we're really keen to look at, because it could be a PKD specific mechanism that we could then work would be a particular target to explain why the process is even more accelerated in people with PKD.
Wonderful.
Thanks,
Sounds
Jess.
very interesting. And also a lot of work ahead of you
Yes,
and
yes.
your team. One of whom I saw was actually on tonight's webinar, which was
Oh,
really
good to know.
fantastic.
Good to know.
Yes. Well, no more questions have come through. So one more that I also like to ask our researchers is how did you actually end up researching polycystic kidney disease? How did you fall into it?
Okay, no, look, really good question. So my area of research before I sort of moved into polycystic kidney disease was looking at cardiovascular disease and looking at high blood pressure. And so a lot of the work we've done, particularly even now with our models, is looking at what causes high blood pressure. We look at both how the brain causes high blood pressure, what happens in the heart, what happens in the blood vessels, what happens in the hormones. So there's so many things that contribute. So we were working with preclinical animal models for various reasons, because they allow us to study some of these mechanisms in quite controlled circumstances. And where I was working in Perth in Western Australia, I worked quite closely with one of the facilities there that had a spontaneous mutation that caused a form of polycystic kidney disease. And so that's actually the LPK model that I talked about today, the Lewis polycystic kidney model. And so because one of the first things we did with those animals, look at their blood pressure, which was really high, we realized they'd be a really good sort of model to look at blood pressure. But that really then drove very quickly into, hang on, polycystic kidney disease is the primary issue here. Why is that associated with such high blood pressure? And it sort of went on from there. We wanted to work out why these animals had polycystic kidney disease. So we identified the genetic mutation, which drove my work into some of the research we do in cyst development and what causes cysts. So it sort of all flowed from there. So yeah.
I love that. And then it just brought you over further and further.
And that's where I live. So now, yeah.
Oh, that's so great. That's so great, Jackie. Thank you. We've actually just had one more comment come through saying it was a really fantastic presentation and well answered questions. And thank you.
Thank you very much. And,
And I must say, thank you. Thank you so much. Oh, wait, one more question has come through. Question about diet. Are there any other dietary factors that can influence calcification?
I honestly don't know. No, I really don't know. So yeah.
Thank you, Tom. We will take that question on notice.
Take that one on notice. Yes. Yes.
There is a lot happening in the dietary space, and hopefully that is a question we'll be able to answer soon. One more question's come through. Would you be able to tell us a bit more about your work and the team at Macquarie?
Yeah, so look, I've been at Macquarie University now since 2009. I work within a broader group of research groups that look at we're really interested in the physiology of the cardiovascular system and the respiratory system. So I work closely with a number of people in that space. I work particularly close with a lady called Associate Professor Cara Hildreth, who some of you may be aware of. Her work focuses very much on the brain and how the brain controls blood pressure. And she's done a lot of work in collaboration with us as well, looking at how in PKD, the brain changes both in terms of the nervous signals it sends to the body to control blood pressure and also the hormones that the brain controls to control blood pressure. So we looked at water regulation and thirst, and water as a factor in PKD is an important part of that. So that was a really exciting piece of work that we've been doing with Cara. The work that I presented today is work that I've been doing in collaboration, as I mentioned, with Simi and with Ashley. And we also work closely with a team that look at that pulse wave velocity that I talked about. That's their expertise. So we work with them looking at pulse wave velocity in our animals to see what that is and if we can change it with our various interventions. And we also look at, we've talked to Mark about work that they do in pulse wave velocity in people, and people with chronic kidney disease is something we're really excited to potentially be looking into as well. So yeah, there's some of the different things that we do.
So many avenues to go down. And yeah, we had the privilege of hearing from Cara last year. And if anyone's wondering where that webinar is, it's not yet on our YouTube because there is an embargo on the research. So we're waiting for everything to be published, but don't worry, I have not forgotten. And hopefully we'll be able to release that. So if anyone missed out on hearing about the brain and blood pressure and that side of the research, that will be on our channel and we'll get to hear about that. We have another question, and I'm not saying I'm throwing you under the bus with this one, but is there a possibility of perhaps visiting your lab?
Absolutely. Look, we'd love to do that. I know that we recently, there was a visit to one of the labs in Melbourne. We're delighted to facilitate something for people to come and visit our labs at Sydney at Macquarie University. That'd be fantastic.
Yes, don't worry. We will be working. I'll be personally working with Jackie on that and organizing another lab visit because we would love to have our community be able to go and actually see firsthand part of the incredible research effort that goes into polycystic kidney disease. All right. Well, I believe that is all the questions for now. So, I just wanted to say thank you again so much for taking all that research and condensing it in a way that we can understand, and just helping us understand the risk as well around cardiovascular, nope. I've been admiring the whole time that you can say vascular calcification and cardiovascular and atherosclerosis. I'm not even going to try. And you barely stumbled. It's tongue twister after tongue twister. Thank you, Jackie. Thank you, everybody, for attending on behalf of our community and on behalf of our other board members as well. Thank you for presenting this evening.
No, look, it's a pleasure, and they'd be happy to take any questions afterwards, and really value the opportunity to speak to people about what we do, why it's important, and hopefully that, you know, with support of foundations like PKD Australia, that we can actually make a difference and progress and find a treatment, a cure, and alleviate all the symptoms that are associated with this condition. So.
Well said. Thanks, Jackie.